Hello class, hello Dr. Petko. My name is Ibrahim Diallo. My clinical site is Feroz Pediatric located in Clifton, New Jersey. My preceptor is Dr. Gadala Hisham. In this video presentation, FNP 597 week 6 case presentation, we want to describe why the case is meaningful. We're going to talk about a brief description of the case, and then we're going to talk about the resources that we use and then the holistic approach of the case. So let's dive right into it. The patient is a KW 70-year-old African American who came to the clinic with her dad, alert and oriented to time, person, place, and situation. She's a reliable historian. She reacts to verbal and tactile stimulation appropriately. She's well groomed and appear well she's well groomed and appear well and able to answer the questions correctly. Chief complaint KW complained that my right eye is red, itching, and watery since last night after I came back from my dance class. There was a pus on it this morning. I cleaned it in the shower, but it is back again. History of the present illness. The patient stated that it started last night when she got back from the dance class, and her right eye is watering and itching, and she wake up this morning. The right eye is red, smaller than the other eye, and she saw a pus on the lids and on top of her eyelashes, and she felt it was disgusting. She said she cleaned it this morning in the shower, but it came right back. And after she ate breakfast, she tried to lay down, and then it got even worse. She said she didn't take any medication, and she told her dad she wants to go to the doctor. Past medical history. She does not have any significant past medical history except she had a left femur fracture 10 years ago, and she's taken ibuprofen 600 milligram PIN Q4 hours for menstrual pain. No over-the-counter or herbal medication, no allergies to food, environment, or medication. Immunization is up to date. Patient family history: the grandfather, 66-year-old, alive with hypertension and rheumatoid arthritis. Grandmother, paternal side, 65, alive with history of hypertension, obesity, and low back pain. Grandfather, maternal side, 61-year-old, alive, history of pneumonia and hypertension. Grandmother, maternal side, 64-year-old, alive with history of obesity and GERD. Father, 40-year-old, with a history of COVID-19, hypertension, and obesity. Mother, 35-year-old, pre-diabetic, obesity, and hypercholesterolemia. Sibling: she has one brother, 20-year-old, from another mother, living in Virginia. No health record was provided. Social history: second child from the father's side, first from the mother. Both parents are employed. She attends school online. Hobbies: she likes dancing, singing, and listening to music. She does not smoke, drink, or use illegal drugs. She have not been abused, bullied, or victim of any type of physical assaults. She followed direction from both parents, and she displayed a pleasant relationship with the dad. She eat healthy diet, exercise, sleep well, and there is no psychological or behavioral disturbances. She has been exposed to COVID-19, but her results turn out to be negative. Growth and development: normal growth and development, normal height and weight, body well developed without deformity, sign of pubertal development are present and normal. As per the patient, she's sexually inactive. She has interest female male relationship. She likes using digital computers, social media, and wants to be a songwriter in the future, as per the patient and the dad. Health promotion and maintenance: immunization are up to date. Last normal annual physical was in December 2020. She doesn't use any illegal drug, alcohol, tobacco, or any unhealthy food. She sleep well, live in a growing live and grow and in a safe environment, and she has a appropriate learning environment. She expresses happiness and great relationship with the parents. She's alert about STDs and the need to protect herself. She's dedicated to schoolwork, family, and social interactions. Review of system constitutional. The patient does not have any fever, chills, weakness, fatigue, abnormal weight changes. Um, Head, ears, nose, mouth, neck, and the throat. She deny any concern. The eyes. The patient complained about red, itchy right eye with yellowish discharge, swelling, and sticky right eyelids. She denied pain in the right eye, foreign body sensation, photosensitivity, visual disturbances, problem with night vision, blurred vision or pressure. She denied similar symptoms in the left eye, denied visual disturbances bilaterally. She denied any concern in other body systems. Objective information: vital signs are normal. General: no fever, no chill, no abnormal weight changes, no weakness or fatigue. She appeared healthy except for the red eye. She's well groomed, awake, alert, and oriented to time, person, place, situation, and time. The eye. Um, on observation, the right eye appeared slightly smaller looking. It looks like it wants to close. Um, most It looks like it wants to close, um, and the smallness of the eye is noted mostly on the outer part of the lateral side of the eye, the right eye. The redness affects the right globe uniformly, but it does not reach to the external borders of the lenses. The redness is also noted uniformly, on her tarsal area of the right eye, and the inner lower upper lids are affected by the redness. It also has a swelling appearance. Her right eye vascular bed is well pronounced uniformly, with swelling appearance. Yellowish and thick discharge noted on her upper and lower lids. Um, on Yellowish and thick discharge noted on her upper and lower lids, to the inner canthus area and on top of the eyelashes, mostly on the lower lashes. The lower eyelashes kind of get stuck together, especially toward the inner canthus. On palpation, the discharge is sticky, and both lower and upper lids are mildly tender and shiny looking. Visual acuity is intact, vision 20/20 on the right eye. Peripheral and central visions are intact. The ocular muscles are intact without nystagmus. She's able to read, with the affected eye. Uh, compared to Compared to the left eye, none of these symptoms, are verbalized. Her vision is 20/20 in the left eye. The central and peripheral visions are intact without nystagmus. Both eyes have a similar central and peripheral vision, with ocular muscles intact bilaterally. No nystagmus on either eyes. Both eyes are parallel. The patient is able to read clearly with both eyes without difficulty distinguishing color. No inflammation is noted on her pupils bilaterally. No sty is observed. No pertinent or recent diagnostic, um, in her past medical history. Although important consideration is the fact that she uses ibuprofen 600 milligram every 4 hours PRN for menstrual pain. And the reason for that is because ibuprofen, can cause abdominal mucosal irritation, which can increase the risk of group A bacterial infection in the stomach. Differential diagnosis. Viral conjunctivitis is ruled out as evidenced by unilateral diffuse shiny redness, edematous eyelids on the right eye, itching on the right eye without watery mucoid discharge or follicles on the palpebral, absence of periauricular lymph node tenderness, absence of burning sensation or feeling of sand inside the affected eye, no current or history of upper respiratory infection, rhinitis, lesions on the nostrils, photophobia, and fever. Herpes zoster, ophthalmicus also ruled out as evidenced by absence of eye pain, photophobia, mucoid discharge, cloudy cornea, headaches, malaise, fever, a rash around the forehead, nose, cranial nerve involvement, uveitis, keratitis, and history of current viral herpes zoster infection. Bacterial conjunctivitis ruled in as evidenced by an onset of 24 hours of diffuse and shiny redness observed on the right eye, affecting the right globe uniformly. Uniform redness on the tarsal area of the right eye, the inner lower and upper lids of our right eyes, a pronounced vascular bed with swollen appearance of the eyelids on the right eye, yellowish and thick sticky discharge upon awakening in the morning, absence of recent upper respiratory infection, and absence of visual disturbances. Diagnostic evaluation. After history and physical examination, we'll perform a rapid viral test, to rule out adenovirus or bacterial infection. Detailed eye examination looking for pupil dilation, abrasion, or other lesions. Also, blue pen light fluorescent staining with the anesthetic drop can be also used, before the evaluation, or gram stain or culture to clarify the suspicious bug. Treatment plan. Non-pharmacological treatment. Wash your hand at least 20 seconds. Apply cool compressions and clean the affected eye from with a warm and moistened cloth from the inner outside, from the inner inside toward the outer outside. I'm sorry, clean from the inner to the outer. Alternative treatment. In my judgment, for this particular case, I do not recommend alternative treatment because those alternative treatments are not recommended by FDA and they're not supported by evidence-based practice. Pharmacological treatment. Erythromycin 5 milligram per gram ointment. Deposit 1.25 centimeters of ribbon of the ointment on the lower lids for the treatment for 7 days. Patient education. Follow the antibiotic treatment for 7 days. Apply the ointment as prescribed. Avoid the tip of the ointment tube, touching the affected eye. Wash your hand before and after, applying the ointment for at least 20 seconds. Avoid using makeup products during the therapy. Sleep on the affected side, to avoid contaminating the other eye. Monitor and report any visual changes when you start the therapy. Avoid touching your eyes with your bare hands. Report side effects of erythromycin such as hypersensitivity reactions, severe burning, stinging, and eye irritation. Additional patient education, sexual education, ibuprofen use, hypertension due to family history, health and nutrition, and exercise. Follow up within 7 days and notify the nurse practitioner immediately if there's any visual disturbances. The resources that we use to narrow the differential. We use the book Systemic Review, evidence-based from Systemic Review, Clinical Preceptor, and the school library. Our critical thinking process here, basically we're trying to link the chief complaints to the history of the present illness, the patient's past medical history, family history, physical examination, and the living arrangement of the patient, to see if there's any connection, to make sense of the data provided by the patient. Um, this part is very important because basically the information the patient is providing is important in the sense that we have to connect all these different steps, from the history, chief complaint, family history, and the physical examination, to narrow down the diagnostic process. Application of evidence-based practice. We apply evidence-based practice. We review systemic. We check out information about the treatment on the systemic reviews. We look at the books, and also consult the preceptor. Holistic approach and caring science. The holistic approach for this patient here, although the patient came in complaining about, a redness of the right eye, we still looked at the entire picture, the patient's living environment, growth and development, health promotions and disease prevention, healthcare cost, healthcare access, other chronic conditions that are associated with the patient's complaint, and we looked at the living arrangement, and income, geographical location, and so on. For this particular case, we use Gene Watson's characters process called human caring trusting relationship. This is the one we use in this concept because when the patient and the parent come to the clinic, they rely on us, to look for the best evidence possible, to apply it in the care plan for the patient and make sure they get the best treatment available and at a cost effective. So basically, like I said earlier, the reason why I chose this case particularly is because bacterial conjunctivitis, can be conjunctivitis can be caused by bacteria, by viruses, allergies, toxicity, medication, or childhood infection. So it's a very, very kind of complex to distinguish between all these different type of causative factors. So the case is relevant, for me to be for me to present it because it represents not only more than 1% of the primary care visit in a year, but the cost is over $900 million, associated with the primary care visit. So and 50 to 75% of the cases of conjunctivitis are usually handled by the primary care physician. So it's important to clarify that not every every conjunctivitis case is associated with a red eye, but not every red eye is considered to be a bacterial conjunctivitis. So clinically, it's very important to know also the anatomic locations of the redness, which is very, very important in distinguishing and narrowing down the differential diagnosis. So basically, this is the end of the case presentation. I hope I presented the case very clearly, and I thank you very much, Dr. Petko, for all your positive feedback. And I'm just very glad that I have been in your class, and also thank you to my classmate. Thank you very much for listening to my presentation.